Good morning. Ready?
Yes, sure.
All right. Subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. Today, we are addressing the quality of medical imaging and radiation therapy services and their impact on patient safety and cost. I'm sure that many people would be surprised to learn that there are no uniform licensure standards for the technologists who perform tests such as MRIs and CT scans every day in our country. Currently, radiologic technicians are regulated at the state level, and those standards can vary widely between states, from those with stringent standards to those that do not regulate the education or competency of these medical professionals at all. Patient safety can be impacted by improper positioning or poor technique by the technician, which can lead to misreading of scans and a need for duplicate tests. These tests cost Medicare billions of dollars every year, and we cannot afford to pay for multiple tests that should have been done right the first time. I'm a firm supporter of a bill by our colleague Ed Whitfield, H.R. 2104, the Consistency, Accuracy, Responsibility, and Excellence in Medical Imaging and Radiation Therapy Act, or the CARE Act. This common sense bill enjoys bipartisan support and has been the subject of 3 hearings in this subcommittee over the last few years. It would direct the Secretary of HHS to 1, establish minimum standards for personnel who perform, plan, evaluate, or verify patient dose for medical imaging examinations or radiation therapy procedures. 2, establish a program for designating certification organizations after consideration of specified criteria. 3, provide a process for the certification of individuals whose training or experience are determined to be equal to or in excess of those of a graduate of an accredited educational program. And 4thly, publish a list of approved accrediting bodies for such certification organizations. Medicare reimbursement will be contingent on meeting the minimum training standards. I know that we have witnesses representing imaging and radiologic technicians here with us today, and I look forward to their insight and expertise in this area and their thoughts on the CARE Act. I'd like to thank all of our witnesses for being here, and I look forward to your testimony. And at this time, I yield to the gentleman, Mr. Whitfield.
Thank you very much, Mr. Chairman. I genuinely appreciate you and Ranking Member Pallone working with us on this important legislation. I certainly want to thank Mr. Barrow, who is a co-sponsor of this legislation, a lead co-sponsor of this legislation. All of this started, at least for me, a couple of years ago, I guess 2010, when we had a hearing and we had some people here involved in linear accelerators. And there was a case up in New York where the patient was severely burned. And as a result of that hearing, it came to our attention, although I'm sure people like Dr. Gunderson and Dr. Martino knew this already, but it was quite obvious that all states do not require licensing for these technologists, and those states that do, frequently the standards are quite different. And so the purpose of this legislation is simply to ensure that patients undergoing imaging or radiation therapy can feel comfortable that the personnel performing those procedures are qualified to do so. And we have approximately 130 co-sponsors of this legislation, and I think it is an important piece of legislation, and hopefully I look forward to working with all of the members of this subcommittee and the full committee to try to get this legislation to the floor as soon as we possibly can. Thank you.
And I'll yield the remainder of the time to the Vice Chairman, Dr. Burgess.
I thank the Chairman for yielding. Both radiation therapy and medical imaging are important. Critical medical advancements, and when used properly, save lives and should be used only when necessary and utilized properly to employ the safe use of radiation. That's kind of where the similarities end. Radiation therapy is just that. It is a treatment. Imaging is a screening tool. It is the difference between taking a picture and doing an operation. With medical imaging our goal, the goal should be to employ the lowest radiation while achieving the clearest picture. With therapy, it is to employ the most concentrated dose and achieve the goal of killing the tumor. With imaging radiation as a secondary thought, well, with therapy, it is actually the tool that is used. In developing this, looking at our file cabinet under R and pull out the first two things that contain radiation and trying to lump them together may not be in the best interest, but there's no question that they both need to be properly utilized. But once again, our approaches to two very different areas to address different issues. Certainly, we should do everything in our power to make certain that providers, whether it be hospitals or doctors, reduce redundancy and only take an image one time if only one image is indeed necessary. The creation of radiation benefit managers is something that concerns me, and it's a clear way to achieve denial of service rather than enhancement of service. On the therapy side, we need to look at the improved technological safeguards, increased medical education, specialty society accreditation, as was mentioned by the chairman, and coordination of medical professionals. Mr. Chairman, I thank you for the consideration. I'll yield back the balance of my time.
Chair thanks, gentlemen. Now yields to the ranking member. Mr. Plone, 5 minutes for opening statement.
Thank you, Chairman Pitts. Today, the subcommittee is meeting to discuss the appropriateness of standards for medical imaging and radiation therapy technologists. I'm glad that we're having this hearing because it's an important patient safety issue. When I was a chairman, we held a hearing on the overview of medical radiation, and Mr. Whitfield talked about it, and that was in response to a series of alarming reports in the New York Times on medical radiation errors. And those stories raised red flags, and I felt it was important that members have an opportunity to better understand the landscape. What we learned at that hearing was critically important, and that there were gaps in the oversight of certification and licensing of allied health professionals. We also determined, however, that radiation undoubtedly saves lives because it's reshaped the world of diagnostics and has offered patients less invasive alternatives for treating complex and life-threatening conditions. In addition, a direct result of the examination of this subcommittee has led to a number of efforts underway within the imaging field. In 2010, FDA launched the initiative to reduce unnecessary radiation exposure for medical imaging and working with manufacturers to improve the safety of imaging equipment through its regulation authority. In addition, in 2010, through the Medical Imaging and Technology Alliance, or MITA, manufacturers developed the CT dose check standard, which includes features that assist an imaging team in providing better care. In addition, MITA is currently finalizing the CT access control standard, which will produce an extra safeguard that will ensure only an authorized operator can alter the controls of a CT scanner. And these efforts are commendable and should continue and be expanded. But there's clearly still work to be done to better ensure that the driving factors of why things go wrong are rectified. One issue that still remains is licensure and certification. While advancements in the industry become more complex and complicated to operate, in many states, individuals who operate these devices do not need to be licensed and are therefore not regulated at all in terms of education and expertise. Even in states where there are licensing requirements, the requirements are weak and not enforced, and I just don't think that's acceptable. So that's why Representatives Whitfield and Barrow have introduced the CARE Act, a bill that would establish standards for the personnel who perform medical imaging examinations or radiation therapy procedures. This seems like common sense policy and a legitimate first step in addressing radiation safety, and I hope that the subcommittee will consider that bill in the near future, Mr. Chairman. What we also know is that we have no idea how often errors occur and have no good data on where the weaknesses in the system truly are. So I do think there's a need to find ways to ensure that patients do not receive radiation doses in excess of recommended levels. I look forward, Mr. Chairman, to hearing from all our witnesses. We appreciate your taking the time to speak to the subcommittee on this very important issue. And I'd like to yield the remainder of my time to the gentleman from Georgia who's the Democratic sponsor of the legislation, the CARE Act.
I thank the gentleman, and I thank Chairman Pitts and especially Chairman Whitfield for his leadership on this issue. I'm glad we're having this hearing to shine a light on the fact that not all the folks performing radiation diagnostics and treatment are properly trained. Many people I represent are shocked to hear that. They know that it's a direct threat to public health when radiation technology is misapplied, and it's also an economic problem because of the direct and indirect costs of poor image quality. Along with Chairman Whitfield, I'm the lead co-sponsor of the CARE Act, which will address this issue by requiring a standardized certification process for radiologic technologists. I think that's common sense, and I hope and expect it to be the consensus position of this committee. I look forward to hearing from the witnesses and hopefully to moving this bill forward. And with that, Mr. Chairman, I yield back the balance of my time.
All right, the chair recognizes the ranking member of the full committee, Mr. Waxman, 5 minutes.
Thank you very much, Mr. Chairman. The focus of today's hearing, the accreditation of medical imaging and radiation therapy technologists, suggests that the certification process is key to maximizing patient safety when radiation delivery is involved. Accreditation of personnel may be an important component of patient safety, but as we learned at this subcommittee's hearing on medical radiation in the last Congress, it is not the silver bullet. Let me be clear at the outset. Diagnostic and therapeutic radiology interventions save lives and improve health outcomes. They're important procedures in our medical toolbox that unquestionably have made our healthcare system better. CT scans minimize the need for exploratory surgery. Radiation therapy aids in the treatment of breast and other forms of cancer. Even the basic X-ray plays a critical role in modern medicine. But with this technology comes an important obligation, making these interventions as safe as possible. Of course, that includes qualified technologists, but it also means the delivery of the right procedure at the right time and with appropriate dose of radiation. Patients are entitled to nothing less. Since we last met on this topic, there have been some notable advances in the public and private sectors alike. Consider the following. CMS has developed an accreditation process for physicians and other non-hospital providers who bill Medicare for advanced imaging services. The FDA has launched an initiative to reduce unnecessary radiation exposure in medical imaging, and several professional societies are working to communicate best practices to health professionals and patients, and to begin to capture data on the amount of radiation patients are receiving. These efforts should be commended and continue to move forward, yet deficiencies still exist. We find only a patchwork of state regulation for the technologists who position patients and deliver radiation doses, and far too many patients continue to receive radiation doses in excess of recommended levels. Today's hearing will examine all of this, hopefully with an eye on the ultimate prize, ensuring that all medical radiation services are designed, delivered, and monitored with the highest quality of care. I look forward to hearing from our witnesses this morning, and I thank each of you in advance for your testimony. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. That concludes opening statements for the members. The chair requests unanimous consent the following statements be introduced into the record. Statement of the Society of Nuclear Medicine Technologists section, statement of the American College of Radiology, statement by the American Society of Nuclear Cardiology, statement of the American Academy of Ophthalmology, statement of the American Association of Physicists in Medicine, statement of the Medical Imaging and Technology Alliance, and a statement of the Society of Diagnostic Medical Sonography. Without objection, so ordered. I'll introduce the panel at this time. Today's witnesses are Mr. John Spiegel, who's the director of the Medicare Program Integrity Group at the Centers for Medicare and Medicaid Services, United States Department of Health and Human Services. Dr. Leonard Gunderson, chairman of the board of directors for the American Society of Radiation Oncology and emeritus professor and consultant in radiation oncology at the Mayo Clinic. Dr. Rebecca Smith-Benman is a professor in the departments of radiology and biomedical imaging, epidemiology and biostatistics, and obstetrics, gynecology, and reproductive sciences at the University of California, San Francisco. And Dr. Salvatore Martino is a registered radiologic technologist and is the chief executive officer for the American Society of Radiologic Technologists. We're happy to have all of you with us today. Your written statements will be made a part of the record, and at this time you're recognized for 5 minutes each to summarize your testimony. Mr. Spiegel, you're recognized for 5 minutes.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, I'm pleased to be here today to discuss the role of the Centers for Medicare and Medicaid Services in accrediting suppliers of advanced diagnostic imaging services. CMS is working to ensure that Medicare beneficiaries receive advanced diagnostic imaging services from suppliers that meet quality and safety standards. Section 135 of the Medicare Improvements for Patients and Providers Act of 2008, or MIPA, requires that beginning January 1st, 2012, Medicare can only make payments to the supplier of the technical component of advanced diagnostic imaging services if the supplier is accredited, including personnel standards, by an accrediting organization approved and designated by the Secretary of the Department of Health and Human Services. CMS has implemented these statutory provisions. This advanced diagnostic imaging accreditation requirement applies to MRI, CT, nuclear medicine, including PET. The law also gives the Secretary flexibility to expand the scope of the diagnostic imaging to which the imaging accreditation could apply, but the statute specifically excludes X-ray, ultrasound, and fluoroscopy procedures. MIPA requires the Secretary to approve organizations that then accredit advanced diagnostic imaging suppliers. By law, the accrediting organizations must establish standards in specified areas, including qualifications of personnel performing advanced imaging services, qualifications of medical directors and supervising physicians, procedures to ensure that the equipment used meets performance specifications, standards to ensure that the safety of both beneficiaries and staff performing the imaging test, and quality assurance and control program to ensure the reliability of the diagnostic images. CMS selected 3 national accrediting organizations that meet all the standards and requirements prescribed in MIPA: the American College of Radiology, the Intersocietal Accreditation Commission, and the Joint Commission. MIPA provided that suppliers previously accredited by one of these approved accreditation organizations did not need to seek new accreditation to comply with the MIPA requirements, but must continue to maintain their accreditation. As of May 25th this year, 15,821 accredited, there are 15,821 accredited suppliers in a total of 61,434 locations, 2/3 of which are accredited by the American College of Radiology. The accrediting organizations designated by the Secretary have developed detailed standards that address the qualifications of individuals performing the technical component of advanced diagnostic imaging. Each accrediting organization has developed specific guidelines for staff performing different advanced diagnostic imaging modalities. For example, the ACR requires that radiologic technologists performing a CT be certified by the ARRT or have a state license, have documented training in CT, and complete various continuing education requirements. The other accrediting organizations have similar requirements or assurances. In states where there's a licensure or certification requirement, the accrediting organization standards include those state requirements. However, the accrediting organizations personnel standards go beyond these minimum state requirements to include a range of standards that address different aspects of advanced diagnostic imaging. This assures that only technicians and technologists that meet the experience and education requirements established by the accrediting organizations are considered qualified personnel. CMS believes that the MIPA accreditation provisions strike a careful balance by focusing oversight and attention on areas of imaging that pose the greatest risk to patients in a manner that minimizes the burden imposed on physicians and others who furnish imaging services. The exclusion of X-rays, fluoroscopy, and ultrasound from accreditation requirement limits burdens on individual physician practices, especially primary care physicians who may perform these tests in their offices. The use of accrediting organizations as required in MIPA enhances patient safety. This approach enhances patient safety without the need for additional direct federal government oversight of every supplier of advanced diagnostic imaging that serves Medicare beneficiaries. As physicians increasingly rely on advanced imaging services to diagnose complex medical conditions. The MIPA accreditation requirement provides Medicare beneficiaries with assurances that imaging facilities have well-trained staff using safe machines and procedures to conduct diagnostic imaging tests. We'll continue to work to fulfill our statutory requirements to oversee this accreditation process and ensure that accrediting organizations, suppliers, and beneficiaries continue to have the information they need on these requirements. Thank you, and I'd be glad to answer any questions.
Chair, thanks, gentlemen. Dr. Gunderson, you're recognized for 5 minutes for your summary.
Chairman Pitts, Representative Pallone, and members of this distinguished committee, good morning and thank you for the opportunity to testify at today's hearing. ASTRO and its over 10,000 members applaud the leadership of Representatives Whitfield and Barrow for sponsoring the CARE Act, which has broad bipartisan support in this committee. ASTRO strongly supports immediate passage of the CARE Act, which is a key component of our patient safety initiative. I'm an emeritus professor and consultant in radiation oncology at the Mayo Clinic, where I practiced for 28 and a half years, 21 years in leadership positions. I'm the chair of the ASTRO Board of Directors, who I am representing today. I care deeply about my profession and the health and safety of our patients. It is important to note the marked difference in the use of radiation for treatment of cancer patients versus for diagnostic purposes. In diagnostic radiology, low doses of radiation are used for imaging studies to determine if problems exist. With radiation oncology, we use high-dose radiation to kill cancer cells, and we often find better results with higher doses. When a patient is diagnosed with cancer, a radiation oncologist discusses and agrees upon treatment options with the patient and their family. We plan and deliver that care with support from non-physician members of the radiation oncology treatment team. This treatment team consists of a medical physicist responsible for quality assurance programs and making sure the equipment is working properly, a dosimetrist who carefully develops a computerized plan in conjunction with the radiation oncologist to make sure the cancer gets the prescribed dose while nearby healthy tissues are spared, and a radiation therapist or technologist who administers daily radiation treatments under the physician's supervision. ASTRO has long advocated for Congress to improve the safety of radiation therapy by establishing minimum education and credentialing standards. As you are aware, some states' basic training standards are voluntary, allowing individuals to perform some radiation oncology procedures without any formal education. Without a minimum level of standards, patients are at risk. The CARE Act would set needed education and certification standards for radiation therapists, medical physicists, and medical dosimetrists who participate in the delivery of radiation therapy for Medicare patients. These minimum standards will help ensure that patients are treated accurately and safely, leading to reduced complications and potentially higher patient survival rates. We are concerned about proposals to expand MIPA in lieu of proceeding with the CARE Act. As you know, MIPA applies only to advanced diagnostic imaging services provided in freestanding centers, not radiation therapy services. If MIPA were simply expanded to include radiation therapy services, we are concerned that the vast majority of radiation oncology patients won't benefit because they are treated in hospital outpatient departments, not in freestanding centers. While a critical step, we do not believe that the CARE Act alone can prevent medical errors that are possible in a complex treatment such as radiation therapy. That is why ASTRO is committed to working with Congress and this committee on additional efforts to ensure patient safety, particularly in the area of practice accreditation, which is different than credentialing the non-physician members of the radiation oncology treatment team. The CARE Act is one of the many pathways toward increased patient safety. ASTRO has been a leader in efforts to improve the quality of care and patient safety, and these initiatives are detailed in our written testimony. Finally, I want to conclude with a story of one of my patients that immediately came to mind when I was asked to testify. It involves a man diagnosed with metastatic terminal cancer that was not responding to chemotherapy. His dying wish was to walk his daughter down the aisle at her wedding. He needed a course of radiation therapy to treat his metastatic cancer, relieve his pain, and hopefully prolong his life. Just before his first radiation treatment, one of our well-trained radiation therapists caught a computer error that, if left unchecked, would have resulted in a less than favorable outcome. We corrected his treatment plan, delivered a high-quality course of treatment. Although his cancer ultimately killed him, It was not before he achieved his wish of walking his daughter down the aisle. This story illustrates the importance of ensuring that every cancer patient is treated by a team that includes top-notch, highly trained, and qualified individuals, which is why we need to pass the CARE Act. Astra wants patients to have peace of mind when it comes to safety, quality, and efficacy of radiation therapy. We urge the committee to immediately pass the CARE Act, and we look forward to working with you on additional policies to further enhance the quality of care patients receive. Thank you again for the opportunity to testify, and I'd be happy to answer any questions.
Chair, thanks, gentlemen. Now recognize Dr. Smith-Benman, 5 minutes for opening statement.
Chairman, Ranking Member, and members of the Health Subcommittee, thank you for this opportunity to testify today. I am Dr. Rebecca Smith-Benman. I'm a professor at the University of California, San Francisco School of Medicine. I'm a clinical radiologist, and I conduct research focused on assessing the risks and benefits of medical imaging. My testimony today focuses on CT because it's one of the most common imaging tests that we use for medical diagnosis, and is also the test with the greatest potential for causing harm because of the amount of radiation it uses. CT uses X-rays to obtain extremely detailed images of internal organs, and the development of CT is widely considered among the most important advances of medicine. In part because it is so useful, the use of CT has increased dramatically over the last 15 years. Last year, approximately 75 million CT scans were obtained, and approximately 1 person in the U.S. per 10 obtained a CT. Although CT is useful, it delivers much higher doses of radiation than do conventional X-rays, and exposure to radiation can cause cancer. To help put this into context, when you go to the dentist and you are offered dental X-rays, you may pause to consider the benefits as well as potential harms associated with getting X-rays. The most common type of CT scan that patients undergo in the U.S. delivers the same amount of radiation as approximately 1,500 or more dental X-rays. In other contexts, people have been concerned about the X-rays that are used at airports to screen passengers. One CT delivers the same amount of radiation as approximately 200,000 airport screens. My research team at UCSF has conducted several research studies to assess the radiation dose patients receive when they undergo CT, and we have found that for every type of CT scan patients undergo, the radiation doses are higher than most physicians are aware, and we have found tremendous variation in the doses between patients in the same facility. For example, one patient may receive a dose of radiation 20 times another, even at the same hospital and for exactly the same clinical problem. Put another way, if a patient goes to a facility to get a CT scan of her abdomen, she has no idea if she'll receive a low dose or a high dose, and yet the patient who receives the higher dose study may be at risk 20 times fold of getting cancer for that examination, while receiving no extra benefit from the radiation dose to which she was exposed. These differences in how much radiation are used for diagnostic CT is not accidental, and yet these are not considered errors, but instead, I believe incorrectly, these are considered and labeled the art of medicine. This sadly is more akin to Russian roulette than personalized health care. There are clear-cut cases of errors in the use of CT when the technologist delivers a dose vastly higher than intended. And when these kinds of errors are made, patients from diagnostic CT can be exposed to doses that cause skin burns, hair loss, and severe damage to the tissue. Thousands of such cases have been reported, and many of these errors happen because of errors in how the technologist programmed the scanner. However, even when CT scanning is done correctly, patients who undergo CT, even a single CT, have an increased risk of cancer, and the higher dose of radiation to which they're exposed, the greater their risk. Since many patients who undergo CT undergo multiple scans, their risks are even higher. An important research paper was published yesterday in the medical journal The Lancet, and that study directly showed that healthy children who were exposed to even a single CT were more likely to develop brain cancer and leukemia. Thus, the doses we experience every day as part of routine CT are potentially dangerous. My research team has studied millions of individuals enrolled in large integrated healthcare systems, and we have found large number of patients receive unnecessarily high doses of radiation because of repeated scanning with CT and because some CTs deliver higher doses than needed. Several people are involved when a CT scan is done. Radiologists order the scan, and they select the protocol or set of instructions that should be used, but it's the technologist who does the study. The console of a modern CT scanner looks a lot like the control panel of a fighter plane, and it's not possible for the technologist to simply press a low-dose button and generate the desired image. Instead, the technologist must make a large number of independent decisions, follow complex instructions on how to program each patient. Yet despite the complexity of the machines and the profound importance of what the technologist does, the technologists who conduct CT examinations receive little education on what doses are excessive, receive no consistent education on how to lower doses they deliver, and there are no consistent standards. In some states, technologists receive only minimal on-the-job training. Further, because there are no uniform design standards, technologists have to scan patients on different machines that all work differently. As part of the research project I am leading to standardize dose, we have organized a large meeting that will be available to all to be held in February of next year. While the meeting will target physicians, physicists, administrators, and referring physicians, the primary focus is to educate and certify radiology technologists on how to understand and monitor and lower the doses to which they're exposed. There's a second and equally important problem that must be addressed, however, to improve the safety of CT. Radiologists determine how the test should be performed, but there are few guidelines on what target doses are desirable. Each radiologist starts from scratch in creating these protocols at their institution. And while the general principle is that doses should be kept as low as reasonably achievable, there are few guidelines about what doses are reasonable or achievable. In order to improve the safety of CT, we need clear standards for what are acceptable levels of radiation for diagnostic CT. The doses used in clinical practice must be monitored. The National Quality Forum, a leading organization that develops and endorses measures of healthcare quality, has endorsed a measure focused on CT. And if facilities follow this measure, they will quickly learn what they're doing and where they need to improve. Lastly, the dose should be reported in every patient's medical record. California recently enacted a law that goes into effect in several months that requires this and provides a template for national legislation. There are a growing number of data monitoring software products that help facilities conduct the kind of dose assessment and monitoring that I'm suggested. And ideally, these dose monitoring software products can be used and can be integrated with manufacturers and radiology information systems to help us work together to enable the electronic capture of patient dose information and inclusion of the information in the medical record. Lastly, oversight of CT is highly fragmented. The FDA oversees the approval of the CT scans, but does not have regulatory oversight for how these machines are used in practice. Through MIPA, CMS has an accreditation process in place that we heard about. Separately, CMS has other authorities to encourage the adoption of quality standards, such as those adopted by the National Quality Forum, that could facilitate facility assessment, reporting, standardization of the radiation dose used for CT, and CMS should be incorporated to incorporate such quality measures in their systems.
Could you wrap up?
Given the importance of CT, and yet its potential for causing cancer, it's imperative that we make CT scanning as safe as possible. These efforts must include education, certification of technologists, the creation of benchmarks, the requirement of recording and monitoring dose, as well as reduction in unnecessary exams. Thank you for allowing me to participate in this discussion.
Thank you. Dr. Martino, you're recognized for 5 minutes for your summary.
Chairman Pitts and members of the subcommittee, my name is Sal Martino, and I am the Chief Executive Officer of the American Society of Radiologic Technologists. I'm also a registered radiologic technologist myself. On behalf of ASRT's 146,000 members, thank you for calling this hearing to examine why we must establish standards for medical imaging and radiation therapy technologists. These individuals perform procedures that are critical to accurately diagnosing and treating millions of Americans each year, from the X-ray that monitors the lungs of a premature infant to the radiation therapy that extends the life of a grandmother fighting cancer. Because these procedures expose patients to powerful doses of radiation, most of us assume that everyone who performs them is competent and educated. But the truth is, unqualified personnel examine and treat thousands of patients every day. That's because Washington, D.C. and 11 states do not regulate radiographers, 15 states do not regulate radiation therapists, and 20 states do not regulate nuclear medicine technologists. In states without regulations, people are allowed to expose patients to potentially dangerous levels of radiation after just a few weeks of on-the-job training. And even in states where personnel are regulated, laws vary widely. Unqualified personnel represent a serious health risk to the American public. Fortunately, a solution is within reach. The Consistency, Accuracy, Responsibility, and Excellence in Medical Imaging and Radiation Therapy Bill, known as the CARE Bill, asks the federal government to establish standards for technical personnel in the radiologic sciences. Under the CARE Bill, anyone who performs medical imaging or delivers radiation therapy would be required to graduate from a formal educational program in the field. They also would have to pass a national certification exam that tests their understanding of radiation protection and patient care techniques. And finally, they would be required to obtain continuing education throughout their careers, ensuring that they remain proficient. Many of you are familiar with the CARE Bill. It was first introduced in the 106th session of Congress in 2000, and it has been introduced in every session since then. In 2006, the Senate passed the bill by unanimous consent, but the session ended before the House could take action. The current version of the CARE Bill, H.R. 2104, has more than 120 bipartisan co-sponsors in the House of Representatives. It also has the support of dozens of healthcare and patient advocacy organizations that represent millions of Americans. Together, we support the CARE Bill for three important reasons. First, the CARE Bill will improve quality. The accuracy of any radiologic procedure depends on the skill of the person performing it. An X-ray won't reveal a broken bone, and a CT won't find a growing tumor if the person using the equipment doesn't know the basics of anatomy, exposure, and technique. Accurate exams lead to diagnosis, treatment, and cure. Poor quality exams lead to additional testing, delays in treatment, and unnecessary anxiety for patients. Even worse, they may cause a misdiagnosis that has tragic consequences. Radiologic technologists must be properly educated to perform their work accurately. Second, the CARE Bill will improve safety. Medical radiation comes with risks. Overexposure can cause skin burns, lead to the development of cancer, and cause birth defects in future generations. CT scanners, Gana cameras, and linear accelerators are some of the most complex technology in the medical field, and patients could be injured or even killed if this equipment is not used properly. Educated technologists know how to properly administer radiation, position patients, and shield organs to deliver the lowest possible dose. And third, the CARE Bill will reduce healthcare costs. More than 300 million medical imaging procedures are performed in the United States every year. Unfortunately, thousands of these exams have to be repeated every day because unqualified personnel made positioning or exposure errors. The federal government pays for many of those mistakes. Medicare spent approximately $11.8 billion on medical imaging in 2009. If we can reduce the number of repeated exams by just 1%, Medicare would save more than $100 million a year. In an era when difficult budget decisions must be made, the CARE Bill makes good fiscal sense. The best way to ensure the quality, improve the safety, and reduce the costs of radiologic procedures is to establish standards for personnel who perform them. For the past 12 years, that has been the straightforward goal of the CARE Bill. It is time to pass this important piece of legislation. Your support for the CARE Bill shows your support for America's patients. Thank you.
Chair, thanks, gentlemen. Thanks all the panel for your testimony. We'll now begin questioning. The chair recognizes himself 5 minutes for that purpose. Mr. Spiegel, we'll begin with you. Can you tell us why MIPA does not include imaging services that are done in the hospital setting? It seems to me that patients in the hospital would be at the same risk of harm as any other patient if these services are performed by personnel that are not adequately trained.
So I wasn't employed at CMS at the time the bill was enacted, but the provisions of the statute don't address advanced diagnostic imaging in a hospital setting. We implemented the provisions that were enacted in the MIPA statute.
Would it be appropriate to address this issue by an expansion of MIPA?
I'm really not in a position to say whether or not hospital radiology needs to be addressed apart from MIPA or some other way. I know CMS has in place hospital conditions of participation that address requirements for imaging in the hospital setting, and we enforce them.
Dr. Smith-Beinman, an individual patient in discussion with their doctor may be willing to be exposed to increased risk of radiation exposure in order to diagnose or treat their cancer. Do you think that if we err on the side of overregulation by, for example, instituting rigid guidelines, that we run the risk of inhibiting patient care and possibly exposing providers of these services to liability?
Two things. I think first, we need to have those discussions between patients and provider that acknowledge there's risks and benefits of medical imaging. So first, those discussions have to happen. Second, if we can encourage facilities to start to look at the doses that they use, they can lower those doses literally overnight. And so part of what I'm encouraging is both looking at doses and then not imposing rigid standards on how to lower them, but just requiring facilities look at how they're doing. And just looking at how they're doing, I've had experience at a large number of facilities, has led to overnight reduction in doses for patients who get very high doses.
Dr. Martino, or any of you, what questions should patients ask the technologist or the radiologist before getting an imaging exam? And what questions should they ask the referring physician before going forward with an exam?
Well, the first question they would ask, and if I took my granddaughter in for an x-ray, the first question I would ask is, are you a certified radiologic technologist? And if they were not, I would not let them take my x-ray or that of my granddaughter. So that's the number one fundamental question for me.
I think going back a step, anytime advanced imaging is ordered, a patient should ask their physician if it's absolutely necessary. Do I need this test? Do I need this test now, or can I wait to have this test? Have I had another test that might help? Or if I do need this test, is it possible to have a test that does not use ionizing radiation? And now currently, we're so enamored with testing that often patients begin that discussion wanting the test without appreciating that there are choices to be made and that there are both risks and benefits. So first to decide, do I actually need to go forward? And then if they go forward, I think the more patients that ask their physicians and their technologists, can you tell me what kind of radiation dose I'm going to be getting from this test, will really encourage the technologists and providers to look at their own data so they can provide really informed information.
Thank you, Dr. Gunderson. Could you tell us why this is an issue that needs legislation rather than something that could come from within the medical societies or perhaps state-level boards?
Well, radiation oncology societies can certainly make recommendations to individuals as far as whether certification should exist, and we certainly do this, but that does not require our members to listen to what we say and to carry it out. And so I think there's an absolute need to have the CARE Act passed so that it does put in place minimum standards. I think of this as a foundation for building further with regard to safety issues, is putting in place the minimum standards that are required by the CARE Act, which societies can encourage but certainly cannot enforce in any way.
I just have 10 seconds, Dr. Martino. Is there any benefit to state flexibility with regard to technician licensing? I assume that the availability of accredited schools varies. Might states with many health professional shortage areas lose out if unlicensed technicians can no longer practice?
No, there are more than adequate radiologic technology programs throughout the country, even in rural areas. And the CARE bill also does have provisions to phase in and allow those individuals to get the additional education that they would need to become certified.
My time has expired. Chair recognizes the ranking member, 5 minutes for questions.
Thank you, Mr. Chairman. I was going to start with Dr. Gunderson. In your testimony, you described differences between diagnostic imaging and radiation therapy, and I wondered if you would elaborate on those differences and tell us more about the varying safety considerations and how might the education and training of radiation therapists differ.
With regard to the marked differences between diagnostic radiology and radiation oncology, as I mentioned, diagnostic radiology uses much lower doses of radiation, primarily for imaging purposes to determine if problems exist, and they're exceedingly helpful to a radiation oncologist with CT imaging or MR to say, here's where the cancer is and here's where we need to focus upon. But in radiation oncology, we use much higher dose levels of irradiation, but dose alone is not the thing that one needs to think about. We use much higher doses where if we're treating with radiation alone, we are going to be delivering often a series of 30 to 40 treatments over a time period of 7 to 8 weeks, treating 5 days a week. And dose alone is total dose becomes important, what the dose per fraction is, and whether we're using it with curative intent or intent to try and totally kill the cancer versus with palliative intent. With regard to what are we doing with regard to patient safety issues, we are very delighted with the provisions that were put into the Patient Safety Act in the mid-2000s with regard to the ability to collect information on medical errors or near misses without there being legal ramifications. We have in fact begun a process of contracting with an existing patient safety organization to launch the first radiation oncology error reporting system. As I noted, we believe the confidentiality provisions provided by the Patient Safety Act are going to ensure that accurate data is submitted and will also mean better participation from radiation oncologists throughout the United States. We think that contracting with the PSO will allow us to meet our goal of collecting radiation oncology patient safety data, analyzing it to improve the safety of radiation oncology, being able to do root cause analyses, and pass that information along to our membership in appropriate ways so that they can learn from it and apply those things in their own practices. And we expect the Patient Safety Organization to be functioning by the end of 2012. Also in our written testimony, we talked about things that we've done starting and expanding on in 2010. Patient safety has always been an important issue in radiation oncology, but with the 2010 incidents, we did a 360 look. We put forward a Target Safely plan, which is discussed in some detail in pages 6 to 8 in the written testimony with regard to working with industry to have standardization of talking across different systems from different providers. We call it the iHero program, to where if we buy one thing from one provider of equipment versus another, that they will talk to one another and that there won't be errors in that. We are interested in practice accreditation. We've written a series of white papers. So there's a number of things we're doing that are outlined in there, and we feel strongly and we'll continue to discuss these with our members and to work carefully with this committee and Congress in trying to improve patient safety.
Well, thank you, Doctor. I appreciate that. I wanted to ask Dr. Smith-Bindman, you testified that credentialing of the personnel who position patients and administer radiation consistent with the goals of the CARE Act is an essential first step in improving the safety and quality of care. That's correct?
Yes.
Okay. But you also mentioned the importance of other strategies to improve safety and quality, such as the development and adoption of additional clinical guidelines, capture of info on the doses that patients receive, and documentation of dose information in the patient's medical record. I want to focus on the tracking and documenting of the radiation dose a patient receives and the quality measure you mentioned. Can you explain why you believe that the adoption of the National Quality Forum endorsed CT quality measures in clinical practice, or one with similar goals, would improve the safety and quality of care?
I think radiologists really want to do the best job that they can, and most radiologists understand that that means lowering the doses and keep them within a very narrow range. But unfortunately, most radiologists currently have no idea of the doses to which their patients are exposed. So if a patient goes to a facility and says, "Doctor, can you tell me how much radiation I got on that exam, or how much am I likely to get, or what kind of doses do you usually give to your patients who undergo an abdominal CT?" Most physicians and most facilities would have no way to answer that question. So by adopting the quality measure, facilities are asked to summarize the doses they're using. What's the average dose in abdominal CT? And that would quickly allow facilities to see how they're doing. And as I mentioned, I've worked with a large number of facilities, and for each of those, the first step of us showing us their data has been surprise that the doses have been so high, and the second step has been to figure out how to lower them. And it's not so difficult to lower them once you figure out the problem. So if patients in general are being imaged for a larger area, well, then you image a smaller area. If patients undergo 4 scans of their chest, and that leads to high doses, well, maybe you want to reduce that to 1. And so I think it's a way to just allow facilities to see how they're doing, to start having standard metrics, so all facilities start using the same words to describe dose and use the same standards against which they're assessing their quality and performance.
Oh, thanks a lot. Thank you, Mr. Chairman.
Chair, thanks to gentlemen. We are in a series of votes that are going to last past the noon hour. We'll take one more line of questioning from Vice Chairman Dr. Burgess for 5 minutes before we break.
My question is, why do we have so many votes? It's going to take us past the noon hour, Chairman. Who thought that was a good idea? Well, Dr. Smith, I just have to tell you, you struck a chord with me with your discussion, perhaps not entirely in the confines of what we're considering on the committee today, but I practiced OB-GYN for 25 years back in Texas, and I recognize, just like you recommend a test or a procedure to a patient, and the next question is generally not, is it safe, is it necessary? Wouldn't even get down to the detail of how much radiation to which I would be exposed, but it's, does my insurance cover it? And if my insurance covers it, suddenly the curiosity drops right off. And perhaps one of the failings of the system, the third-party payment system that we've developed, and why I believe so much in a consumer-directed health care or health savings account, is you got to get the patient back into this equation, and the money is one way to do it. And as a consequence of the patient being in charge of the money, perhaps even the questions about the safe radiation safety or the dosage might be something that's introduced back into the conversation. So I appreciate very much your observation on that, and I'll just tell you, I'm sure it happens. I'm sure it's happening hundreds of times this very morning, where a radiological procedure is being recommended, and there's the patient is anesthetized, and the doctor also may be anesthetized as well, except in our specialty in OB-GYN, when a pregnant woman inadvertently gets an IVP, then suddenly everybody's concerned about what's the doses of radiation that was involved in that study, and then we go into great detail to try to figure it out. Do you have any other observations on that? Because that was a particularly powerful statement that you made.
I mean, in addition to being an academic, I'm a parent who has 3 children. And I have been in many circumstances where imaging with radiation is advised to my children. And in those circumstances, I want to know the risks and benefits to my child of that exam. And I try very hard to go in not as a radiologist, but to go in as a mom. When my youngest fell out of a tree and had a CT scan, that seemed like the right thing to do. He did a head dive out of a cherry tree, and he had a concussion.
And that was your son, correct?
That was
Not
my
your
son.
daughter, yeah, all right.
No, it turns out only the CTs of the head are my son's. But last year he had a very small fall skiing, and I couldn't get a hold of my husband, and I took him to the emergency department. And the emergency department physician told me later that from across the room he could see that my son had a concussion, but knew for sure he didn't have a bleed. And I went in very open. If he needs a CT, he needs it. If not, I'm not going to influence this decision. And the ED doctor said, if you want a CT, I'm happy to do it, but I don't think he needs it. And so I was very happy with that decision. And partly what I do when I educate patients, technologists and radiologists, is to think of every patient as if it's your own family member, and use all the information to decide whether it's necessary, the value of the test, the effectiveness, the risks. And then I agree with you. I think the payment piece has disappeared from our consideration, but it's a very important one.
Thank you. Dr. Martino, I need to ask you, and again, this is a little bit off topic too, but the dosage of radiation that we get when we walk through that TSA scanner at the airport, is that a significant source of radiation for people?
All radiation is not good, but we get it in the environment or whatever. I believe that those are low enough that I don't worry about that. But
bear in mind, you're talking to a panel of frequent flyers here.
Yeah,
Anybody that lives west of the Mississippi is probably
myself
higher
also,
on the
but-
dosage chart.
right. But I mean, it's so low down, you know, compared to what medical radiation is in terms of the individuals that are you know, giving those doses to patients.
Well, I'll tell you why I'm concerned about this. Several years ago in the transportation bill, I tried to get language in addressing the radiation exposure to flight crews. You know, the solar activity varies from time to time, and this is information that is available but not generally dispensed to the airlines, such that they might select a different flight route or altitude because of solar activity and solar radiation that might be emanating that day. So you're right, we've got it in our environment all the time, and as a consequence, any is possibly dangerous, so why wouldn't we do the things necessary to minimize that? So I was a little taken aback when we developed these backscatter imaging devices to, you know, to catch the bad folks, but at the same time, you're putting a lot of innocence through this device, and for those of us up on the dais here, that's twice a week, 35 weeks a year.
Myself included. I would add, though, I think anyone who has anything to do with any kind of equipment that dispenses radiation, even the low doses, say in an airport scanner, should have some kind of minimum knowledge and understanding about what it is that they're operating.
So-
And if there was an error, I mean, it could be a simple, you know, hour course for the TSA scanners that
Do
they
you do
understand.
that? Are they certified in any way as far as radiation understanding?
No, we only, not that I'm aware of.
And did the FDA get involved in this? Because they can be pretty tough on medical devices.
You know, I deal with the certification
All
of
right.
those individuals for medical you know, that are dispensing radiation for medical
Thank you,
purposes.
Chairman. I'll yield back. Thank you.
Chair, thanks, gentlemen. We're in the middle of a series of votes. There are about 5 minutes left on the first vote. We will recess until about 5 minutes after the last vote, which will be around 12:15, I'm told. So we ask for your patience. At this time, the subcommittee stands in recess. All right, the time for recess having expired, we'll reconvene. And we have finished the first round of questioning. We'll go to follow-up with Dr. Burgess for 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Gunderson and Dr. Martino, maybe I could ask you, do you think if we put in place a federal minimum standard for accreditation for technologists that it will restrict entry into that field, and we're going to end up with difficulty filling those positions? Dr. Gunderson, if you'll go first, and Dr. Martino.
At the present time, the main issue, I think, with certification programs and training programs for radiation therapy technologists is the fact that we may not currently have enough training programs that exist out in the real world. And part of that is because some of the programs have contracted instead of expanded. And when I moved from Mayo Clinic in Rochester, Minnesota, down to Mayo Clinic in Arizona, we were surprised to find that there were no training programs for radiation therapists in Arizona. And so we actually worked together with the radiation oncology practices in Arizona and with the community college and actually set up a program which actually required the institutions putting in some financial support because the community college wasn't willing to take that on themselves up front. And so, but we felt strongly enough about the need for a training program with radiation oncology technologists that we convinced our colleagues in what ended up being competing institutions to say the need exists, let's work together and make sure this happens. And that program has stayed as a continuous program ever since that time. So that will be one of the issues, is making sure there are...
Just to be sure, did those programs result in certification of those students who completed the requirements?
They did. They would progress through the training and go on to certification. So that, but it is an issue, and it's why once the CARE Act is passed, we will have to be careful to phase in some of these things so that if there aren't programs that exist in certain states that one has time to put those programs into place and allow them to function. In my mind, it will not prevent people from going into the field because it's a very attractive field, and we have not had any problem at all filling the positions in the school that we created in Arizona, for example.
Very, very well. And Dr. Martini, you may have actually answered that before we went to break, but your thoughts on that?
ASRT has a significant research department, and we do a lot of research and publish research. Every year we do an enrollment survey to see what the enrollment in the educational programs are throughout the country, both in medical imaging and radiation therapy. Right now, in fact, there is a bit of an oversupply of medical imaging technologists, and students have waiting lists in most community colleges, and are.
I could interrupt you for just a minute. What about
Sure.
the geographic distribution, though? Are there areas in the country where it would be more of a challenge to fill those positions?
Not right now. Yes, of course, you have more programs in some of the urban areas, but even in the rural and suburban areas, community colleges are very interested in these kinds of programs because they lead to employment when students get out of school. They've also now raised the requirement starting in 2016. You're going to need an associate degree to enter the field. So many community college programs are now opening. So we don't really expect there to be that much of a shortage in radiography. Radiation therapy, right now there is only a 4.5% vacancy rate in radiation therapist positions. But Dr. Gunderson is right, it is somewhat regional. There are a couple of states that don't have radiation therapy programs, but there are a couple of radiation therapy programs coming online. But both our workplace surveys and our enrollment surveys show that there's more than enough of supply right now to meet demand, and that many of the programs, like nursing programs, have waiting lists to get in because students are realizing that they want to go to college and get a job when they get out, and healthcare is a really expanding area. And in any places where there might be a problem, there is a phase-in period for the care bill, so there should be enough of time for supply to meet demand.
Very well. It's remembering the passage of MIPA in the summer of 2008. It was July of 2008. And we have had another hearing in this committee on this issue back in 2010. And I think Chairman Pallone led that hearing, and we're very grateful for him for doing that. But I'm hard-pressed to recall a hearing on this subject prior to the passage of MIPA. Now, I've only been on the committee since 2004, so staff may correct me that there have, in fact, been other hearings. But it's a fairly significant and fairly complex issue. And when MIPA passed, for those of you familiar with the doc fix, this was the passage of the doc fix. Came up on suspension rather rapidly one summer morning, and nobody ever wants to vote against the doc fix, myself included, because the docs always get mad if you do. But there were all these other ancillary policies that were then cobbled together and thrown on this so-called MIPA bill. And I think it's just a cautionary tale for us here on this side of the hearing room that we must be careful when we take these things on, because they do have far-reaching real-world consequences that affect people in very profound ways, both positively and negatively. And I wish we had taken the time to study this issue a little bit more before the leadership at that time put it onto that bill that came up rather hastily on the House floor in order to make a political statement and cause a stir in the then presidential campaign in 2008. Mr. Chairman, thank you for the indulgence, and I'll yield back.
Chair thanks gentlemen. For follow-up for 5 minutes, Ranking Member Ms. Pallone.
Thank you. I just have a brief question because I didn't get to ask it before of Dr. Gunderson. It was clear from your testimony that you believe credentialing for technologists will do a great deal to improve patient safety. But can you elaborate on why ASTRO believes that additional patient quality and safety activities are an important complement to the goals of the CARE Act?
Rephrase your question
Sure.
as far as
Basically,
how
I
it
just
differs
want to
from the
know,
question you asked.
you said that you believe, or at least I felt from your testimony, you believe that credentialing for technologists would do a lot to improve patient safety. So I just wanted you to tell me why you believe that, that's true, why additional quality and safety activities are important to the goal of, the CARE Act, which is the bill that
Yeah,
You know,
we believe it's important for the three components of the treatment team beyond the physician, the medical physicist, the medical dosimetrist, as well as the therapist/technologist. And if you think of a machine with gears that mesh together, if we have two members of that treatment team that have education and training, but the third person doesn't, then things can fall out of phase and things won't work as smoothly as they need to work. So while the plans that we put in place for radiation therapy are a combination of interactions between the radiation oncologist and the dosimetrist, where the radiation oncologist uses a CAT scan or MRA to say, here's where the cancer is, here's where the lymph node areas are that are at risk, and we contour that. And we also help contour the normal tissues, the healthy tissues that we want to spare. That information then is put into place by hopefully a trained dosimetrist who can integrate that and say, okay, I'm going to put my radiation beams in through all of these angles and put them in place so we can encompass the tumor and protect the normal tissues. That information is then passed on to the therapist on the treatment machine, and as Representative Burgess, I think, talked about previously, if you have somebody that doesn't have the training to make sure that the machine is turned on properly, to make sure the patient's positioned properly, then all of the work done by the radiation oncologist and dosimetrist comes to naught. So this is why we feel there needs to be minimum standards for all components. The physicist is the one that supervises the whole, if you want to call it the safety team beyond the MD, to make sure everything's running properly. And so he's at the top of that safety chain from the treatment team perspective, along with the radiation oncologist. But if the dosimetrists and therapists don't understand what they're doing, then what we envision happening with the safety and care of our patients isn't going to come to pass. And that's why we support the CARE Act for all three components, the physicist, the dosimetrist, and the therapist having adequate training and adequate certification, and why we strongly support the CARE Act.
All right, thanks a lot, and thank you, Mr. Chairman.
Chair, thanks. The gentleman, I'll remind all members of the subcommittee who were unable to attend or return to the hearing that they may submit their questions in writing. They have 10 business days to submit questions for the record. I ask the witnesses to respond to the questions promptly. And I'd like to thank the excellent panel we had today for the information they've shared with us. Members should, by the way, submit their questions by the close of business on Friday, June 22nd. Without objection, the subcommittee is adjourned.
Nice to have met you. Nice to have met you.
Pleasure.
Delighted to share the panel with you.